Welcome to USDTL's ToxTime on evidence-based newborn toxicology. I'm Sandra Andrews, an account development manager at USDTL. Thank you for joining us today. USDTL is a leader in substance use toxicology, known for pioneering tests like Meconium testing in 1991 and Umbilical Cord testing in 2007. Today's presenter is Sukta, our Research and Development Projects Manager, who has extensive experience in forensic toxicology and specializes in non-traditional matrices. Andre holds a Bachelor's of Science degree in chemistry from Benedictine University and a Master's of Science in Forensic Science from the University of Illinois at Chicago. He is also currently working on his PhD in forensic science with a specialty in toxicology at Oklahoma State University. He has worked in various testing areas and holds leadership roles in several professional organizations. He's a director for the Society of Forensic Toxicologists and serves on the executive board for the Alcohol, Drugs, and Impairment Division of the National Safety Council. He is also a member and past chair of the section on cannabis within the Alcohol, Drug, and Impairment Division of the National Safety Council. Andre has also authored multiple papers and presented at many scientific conferences. Now let's welcome Andre Sukta.
Thank you for that intro. Hello and welcome to today's ToxTime on evidence-based newborn toxicology. I'm Andre Sukta, the R&D Projects Manager here at United States Drug Testing Laboratories. Here at United States Drug Testing Laboratories, we're on a mission to make a difference. We have a vision of protecting and enriching lives and a mission of using the best science available to provide cutting-edge tools for the analysis and evaluation of exposure to alcohol, substances of abuse, and toxins. So first off, we should talk about medicines that are prescribed during pregnancy. 7 in 10 women report taking at least one prescription medication. However, between 1997 and 2018, the use of at least one prescription in the first trimester has increased by 35%. And on top of that, fewer than 10% of medicines approved since 1980 have enough information to determine their safety during pregnancy. Pregnancy offers a unique opportunity for treating substance abuse as women's health care issue before it becomes a newborn substance exposure issue. Looking at the National Survey on Drug Use and Health, we can see how substance use in the past month among pregnant females aged 15 to 44 looks. And so I have numbers from 2022 and 2023 from the survey. So if we look at marijuana, we're actually seeing that the pregnant women have decreased some usage of that. Now, it could be that it's legalized, so there's a little less reporting of it. It could be that edibles are not, some people may not consider edibles to be marijuana because they're not actually smoking a joint. So there's a little bit of question in the survey as to what people consider when you say marijuana. Cocaine use does seem to have increased slightly from a 0.1% to a 0.2%. But you'll notice in general, most things have gone down except for tobacco. And of course, that includes nicotine vaping. So people that are vaping while pregnant, that's increased by a full percentage. And so these are all stats that are very interesting. And we look to these to help us make decisions on what we need to do next. But first off, let's get into how drugs in maternal blood can reach fetal blood. And so this is done by passing through the placental intervillous space. There's a layer and fetal connective tissue that reaches the endothelium of the fetal capillaries and then enter the fetal circulation. Placental transfer of drugs can occur via passive diffusion, facilitated diffusion, or active transport. Passive diffusion of drugs occurs for neutral, lipophilic, and unbound drugs with molecular weights less than 500 Daltons. Facilitated diffusion occurs when drugs are structurally related to endogenous compounds such as glucocorticoids. Drug transponders such as multi-drug resistance proteins, P glycoprotein and breast cancer resistant proteins require energy, usually in the form of adenosine triphosphate, to actively transfer drugs. Drug transporters present in the placenta allow drug transfer from mother to fetus and vice versa. So as you can see in this wonderful picture that we got out of the Hudson paper that is cited on the screen, there's a bunch of different ways to transfer drug from mother to child, and we're going to get into that a little bit more in depth. We talk about the passive diffusion, and again, those are going to be most of the drugs of neutral and lipophilic and unbound. That's going to be a lot of what our illicit drugs look like. The facilitated drugs are going to be like the glucocorticoids. Those are going to be like stressors, stress hormones, testosterone, estradiol, cortisol, cortisone. Drug transporters, such as the for active transport, we have transporters that are going to look at these multi-resistant proteins, P glycoprotein and breast cancer resistant proteins. And this is just a little bit more, and that those active transports require energy in order to get that transportation. So they're using ATP in order to get that energy to transfer through the maternal circulation into the placenta. One of the challenges of drug testing in general for mothers that are pregnant is that pregnancy-related changes in these hormones can directly and indirectly affect the pharmacokinetics that we're looking at. So what that means is that there's competition for the drug in binding of the plasma proteins, and there's some changes in the activity of the maternal enzymes, as you can see here in this table. So all of this affects the amount of drug that's going to be in the maternal system at any given time. But some of the changes that we know happen are that mothers will have an increase in renal plasma flow, an increase of up to 80% in some cases. And so what that actually does is it actually helps clearance of the drug. And so it's harder to detect because it's getting out of the system faster. There's a higher cardiac output, so there's an increase of 20 to 45%. And so what this means is that it's actually going to pump through the body faster. But the downside of that is that it increases the chances of absorption because it's able to get into the different spaces within the body. And it affects how much the volume of distribution is. There's an increased volume of distribution as the mother is getting larger by having that newborn. There's also creatinine clearance. And so we see that mothers will have a higher throughput of urine and creatinine, and that just, again, increases the clearance. So that makes it a shorter detection window than what might be in a normal person. There's uterine blood flow, and that increases anywhere from 924% to 2,700%, and that increases absorption. And then there's, of course, the total fat mass, and part of that is that volume of distribution increase, and that increases anywhere from 6 to 23%, according to these papers. So all of these types of changes can affect drug absorption, distribution, metabolism, and excretion. In the toxicology field, we call that ADME. That's sort of what we just abbreviate that as absorption, distribution, metabolism, and excretion. And so as we talk about the placental transfer of drugs, they can be further complicated as the placenta itself contains a broad range of enzymatic activity. Several of the enzymes like cytochrome P450 that cause drug metabolism, they are present in the placenta. So there is some metabolism happening at the placental level. And so they've, along with the cytochrome P450 or that CYP, there's also been some of the other CYPs. There's CYPs 1, 2, and 3 that have all been isolated from placenta tissue. And so these enzymes, along with active drug transporters, alter fetal exposure to varying amounts of parent drug. And so that causes different amounts of metabolites and other byproducts. So for example, some expression levels of the CYP enzymes mature over the course of the pregnancy. So early in the pregnancy, they may not be mature enough to do any metabolism, but as the pregnancy is ongoing, these different enzymes become more active. And so that can cause, some of these drugs and metabolites to become trapped in fetal tissues. Um, and so one of the things that's concerning to us when we talk about this is this fetal swallowing. And fetal swallowing is not the baby breathing, but it's actually the baby swallowing amniotic fluid from the amniotic sac. And so when we're talking about this absorption, distribution, metabolism, and excretion issues, drugs that are starting to get past the placenta into the amniotic fluid through the umbilical cord, there's some excretion by the baby as it passes through the baby's system. And the concerns are really that as drugs are renally excreted by the fetus, it's then being trapped and concentrated in the amniotic sac, and that baby is then naturally swallowing that amniotic fluid. And so now the baby is reabsorbing those drugs through fetal swallowing. And so there's some concern when we talk about that redistribution, because while the baby was able to clear it at one point, now they can't because it's trapped within this cycle of, absorption and then excretion after everything's said and done. So we do have some concerns about that, and we want to make sure that when we're doing our testing, we know what we're looking for. So we talked a little bit about placenta. There's actually quite a few studies on drugs in placenta and whether or not they can be detected, and of course they can. And so that's not what I'm going to focus on for this, but it's going to be about the challenges that the placenta presents for us. So there's been two real studies, one good study and one that was more like a case note. In 2001, there was a study that tested both monozygotic or identical twins, so twins that share the same placenta, or dizygotic twins, so fraternal, so they each have their own placenta and umbilical cords, right? So that's the difference here. And in that study, they were only looking for cocaine, but the cocaine varied if the babies were fraternal. So what they found here is that in the identical babies, they found similar amounts of drug between the two identical babies. So that's great because that kind of indicates that everything that we expect, which is it's coming from the placenta through the umbilical cord and then going to the two babies. And sometimes there might be two umbilical cords, but it's still from the same placenta. In the case of dizotic twins or fraternal twins, there's two different placentas. And in these studies with cocaine, what they found is that there were varying amounts. So one baby had a higher exposure, had higher cocaine levels found in their system versus the other baby, even though they were both in the same womb and grew in the same rates. So that's an interesting study. So we do know at that point that there is something else going on, and it's that placenta enzymatic assay that's maturing over time. And so sometimes they aren't always identical. Every placenta is unique, it seems like, and so that what cuts through the placenta and what doesn't is going to just be based on that particular baby's placenta. In 2018, there was a case study, and this was actually presented by us at USDTL. And what we found was in those monozygotic twins, we actually had discordant results. So as our analysis got more and more sensitive, what we were able to see is that in identical twins, so the one placenta, the two babies would actually, in some cases, one would be exposed with enough drug that it was detectable and the other one could not. And so that was an interesting challenge for us because we're trying to figure out what's going on. And when you have identical twins, as some of the nurses especially will know, sometimes one baby is bigger than the other. So that one baby that's bigger is typically going to have more blood flow. That more blood flow is going to increase their chance of exposure to drugs and chemicals. And so that is going to be part of that challenge. And so even in identical twins, there's some other variables that are going on in order to kind of show it. And part of it is the placenta, and part of it is some of that uniqueness of how they get the blood flow in the twins station. So newborn toxicology testing, it's an important, it's very important for us, and we, because of what our vision is in protecting, enriching lives, we want to be able to help these newborns have the best outcome long term. And so it's important to identify children that are in an at-risk environment. It allows for medical treatment of the neonate. It provides resources and options for the child and family, and it establishes a need for long-term care and or follow-up. Some states also require reporting to their system. Some of those are being repealed over time. We've been seeing that. So there's less and less of that mandatory reporting. But again, testing we think is still very important, because without this testing at this stage in life where we can actually still detect drug and what we know the outcomes are going to be, having this in their file allows them to access resources that may not otherwise be available. So we are still very much in favor and a big proponent of that for those reasons. So let's talk about drug testing for newborns. So there is some option for in utero fetal drug testing. So while the baby is still within the womb. However, methods for measuring fetal drug concentrations are invasive in nature, and they do pose a risk to both the mother and fetus. To minimize risks, the collection of opportunistic surrogate samples during standard of care procedures increase the feasibility of measuring fetal drug exposure. Several of these surrogate options are illustrated. So you can do amniocentesis, where you're testing some of the amniotic fluid, but again, it's still an invasive test and carries certain risks to the mother and fetus. Risks of mid-trimester amniocentesis include rupturing the amniotic sac, miscarriage, needle injury to the fetus, sensitization, and infection. Amniocentesis before week 15 of gestation is associated with a higher rate of miscarriages than midterm, and is rarely performed unless the benefits outweigh the risks. So we just wanted to highlight that there is an option here for that. We also could do umbilical cord blood. The umbilical cord vein provides blood from the mother to the fetus, with the flow established within the umbilical cord by the end of week 5 of gestation. Umbilical cord blood has a unique composition as it contains blood cells with varying stem cell markers and differs from both newborn and maternal peripheral blood. Cord blood can be collected in utero. It's called a cordocentesis. It's usually of the fetal vein, typically between weeks 18 and 34 of gestation, and typically at the time of delivery. Cordocentesis, however, is an invasive test, and so it has risks to the pregnancy. Procedure-related risks include bleeding from the puncture site, which is the most common issue, fetal distress, pregnancy loss, and rarely a vertical transmission of maternal infection. So not ideal by any means. There is also the option to test the placenta. And so there is a way to do some placental tissue testing. And again, doing that placental tissue testing is typically conducted between weeks 10 and 14 during the first trimester. Studies to evaluate drug concentrations from the tissues have not been explored extensively. Some studies have evaluated concentrations of bupivacaine and their enantiomers, lidocaine and fentanyl from the placenta space following term deliveries. But testing the placenta is an invasive test with serious risks to pregnancy. And of course, they include infection, membrane rupture, and fetal loss. So that being said, all of those are an option postpartum. So once the baby's delivered, you can do a lot of that testing afterward. It's a little bit more challenging, especially in the case of amniotic fluid, where the amniotic sac has now been ruptured. But if if you are planning on doing that testing up front and you know that you need to collect it, you can be prepared for that to happen. Again, there is other challenges with amniotic fluid. A lot of times the baby will pass meconium, and we'll talk more about meconium in a minute. But in high risk pregnancies or high stress pregnancies or difficult pregnancies, in about 20% of cases, the baby will actually express meconium during the delivery process. So now the amniotic fluid is also contaminated with meconium. And that could be part of the challenge. But you can test those 3 ways, pre and or post. Also post is meconium. And again, we'll talk about that more in a minute, but that's the baby's first bowel movement. We can actually test the umbilical cord tissue. We can do newborn hair and newborn urine. There are some challenges related with some of those, and so we'll talk about that as well. One of the challenges is that if the baby has been exposed to different compounds, is that and they go through withdrawal symptoms, the onset of those withdrawal symptoms is highly variable. So as you can see, diazepam could be anywhere from hours to weeks, and that's a benzodiazepine. Alcohol could be anywhere from 3 to 12 hours. Heroin symptoms typically show up within 24 hours. Any of the sedatives are 1 to 3 days. Methadone is 1 to 7 days, along with opiates, and barbiturates could be up to 14 days. Prenatal effects of drugs, they have a wide range of impact on fetal development, and it's not limited to our traditional drugs of abuse. So if we look at legal drugs like tobacco, we're looking at things like a decreased birth weight, altered response to stimuli, poorer academic achievement long-term, poorer cognition, attention deficit and hyperactivity, and adolescent aggression. Caffeine has an increased risk of growth restriction and prematurity, and a possible decrease in executive function during the school age. Other drugs, opioids, we have neonatal abstinence syndrome, preterm birth complications, respiratory insufficiency, heart defects, reduced growth, lower IQ, behavior problems, deficits in cognitive and motor ability, and attention deficit hyperactivity disorder. Alcohol has prematurity and spontaneous abortion associated with it. There's limb and facial development issues, reduced growth, cognitive delays and impairments, reduced brain volumes, and deficits in attention, memory, verbal fluency, executive functioning, reaction times, and motor learning. And then the last one that I wanted to just point out was the long-term health effects of marijuana exposure. So when they're newborn, we're talking about low birth weight, premature delivery, increased anxiety and depression symptoms, increased emotional reactions, and reduced separation anxiety. During their developmental years, less branching in the nerve cells, reduced ability to pay attention, diminished problem-solving skills, difficulty with detail-oriented memory, decreased ability to organize and prioritize. And then in adulthood, it's altered brain functions and problems using working memory. And that happens from birth to 22 years. And these have all been studied pretty extensively, and the sources are attached here. So let's talk about newborn urine as an option for testing. Some of the challenges for newborn urine are going to be that they may require a specialized collection device. There's a limited volume just because the babies are so small. There's possible contamination because, again, you have to have a special collection device. Usually then you have to transfer it from that collection device into a jar or into some other vessel. And it's difficult and time consuming. Drug presence, though, it has a short detection window. Of course, as usual with drugs, it's and in urine, it's usually days. So we might be able to detect exposure pre-delivery if it's within a time window of when that urine was collected. There's also some option of the neonatal metabolizing some of the drugs. And so that could be a challenge when you're doing a assay to detect those drugs. Newborn hair. We do have challenges with newborn hair. It is possible, but first off, I think everybody knows that not all babies are born with hair. Monkeys, on the other hand, all have hair. So, but newborn humans don't all have hair at the time of birth. Um, Also, they're typically collected after 1 month, and that's because they're not born necessarily with hair ready to collect. If you are trying to collect it after 1 month, it's a reservoir specimen. It has variable drug uptake and retention, and there's of course contamination possible. And I'll talk more about some known contamination with newborn hair testing in this minute. For drug presence, it will indicate exposure, and it'll typically indicate chronic exposure. But there's also this chance that it's showing environmental contamination because it is a month later. We see a lot of environmental, we do hair testing at United States Drug Testing Laboratories as well. And so we do know that environmental exposure is a big concern. There's a lot of ways for any child to have environmental exposure, even though they aren't necessarily using or touching, but there's a lot of other ways that they can get exposure. And drug deposition occurs in multiple ways. So I was talking for a minute about some of the different contamination challenges that we might face. So this was an interesting issue that came up on most marijuana immunoassays. It provides a false positive from baby wash products. And this was a big concern because there was a lot of clinical testing being done. There was a lot of challenges because suddenly all these babies were showing up THC positive, and it just didn't make sense. And the parents, were adamant that they did not use, did not smoke, did not anything. So what was going on? As it turned out, there were at least 6 commercial baby soap products that showed some level of reactivity with the THC assay. And it wasn't that it's activating for THC, it's just that there was an interferent that was activating the test results. So there was something in that product that caused it to pop positive. And so this is one of the challenges of clinical testing is it typically is done with a single test. You get a result and that you then act on that result. In the forensic world, we always want to have a confirmation test. So we would have then gone to a more thorough mass spectrometry identification and quantitation, and that would have allowed us to note that this wasn't in fact THC, and that's part of how some of this was found out. But Johnson & Johnson's bedtime bath, CVS's nighttime baby bath, CVS baby shampoo, Aveeno Soothing Relief Creamy Wash from Johnson & Johnson, Aveeno Wash Shampoo, Baby Magic Hair and Body Wash, and the only one that really showed no activity was Hospital Foaming Hand Soap. So if they were washing with the foaming hand soap, it didn't have any reactivity. But this caused a lot of problems for a lot of people until this was figured out. And so at USDTL, we always do a confirmation test so that we don't put out a false positive from our screening results. Meconium, as I mentioned a few moments ago, meconium is the initial substance present in the intestines of the developing fetus, and it constitutes the first bowel movement of the newborn. It starts accumulating at about 12 weeks. It is a reservoir specimen, and so sometimes and oftentimes it requires multiple collections, and so that's very typical. And so the collection of that then causes contamination issues or potential contamination issues. And then typically in a normal birth, not a high stress or difficult delivery birth, it's excreted sometime between 1 and 3 days post-delivery. And the presence of meconium stained amniotic fluid is about 12 to 20%. And so that is a challenge. What that means is that up to 20% of cases, the meconium was expressed during birth. And so that means that there's no way to collect that specimen because it was already evacuated from the newborn's bowels. And so 20% of cases, we can't even collect meconium. For a once in a lifetime specimen type, that's a big problem. And so that is one of the biggest challenges with meconium. And typically in newborns going through our exposure cases, they tend to be more difficult deliveries, high stress on the newborn. So that 20%, while it is overall in the testing that we're seeing, it's a much higher increase because these babies are exposed. The other challenge with meconium is the drug presence. It's not homogeneous, so the drugs are not evenly distributed throughout the meconium itself. One of the easiest way to describe what that means is when we say that it's heterogeneous, is that, I hope I don't ruin anybody's appetite, but if you think about a chocolate chip cookie, if the cookie itself was meconium, the chocolate chips would actually be different drug deposits. So that's what we mean when we say that it's heterogeneous. It's not like the egg that was beaten in and spread throughout the entire cookie. It has these little pockets of drugs. So we do our best to homogenize those samples and get them to be fully mixed before we do our testing. But that is one of the challenges, and you need to know that about meconium testing. The analyte stability varies. Some analytes are more abundant, and so I'll talk about this near the end, but you will see some people say that meconium is actually a better specimen than any of the others because of the higher amount of drug that's in there. And that'll be true for certain analytes, but other analytes are not going to be that way. There's also some analytes that are unique only to meconium. One of those is like a metahydroxy benzylagonine. It is a unique product that we only see in meconium. So if there are drugs present, we will see that it indicates in utero exposure. The exposure is typically from the third trimester, so that last trimester. There are some studies that will indicate that it can go somewhat into the second trimester, but it'll be the end of that second trimester. So it's not a perfect like cutoff, right? It's not like, oh, second trimester ended, now drugs are going to be detectable. Like there's some crossover there, but we will just say third trimester because that's when it definitely is going to be available to be able to be seen. And then, of course, there is a chance that we might see some contamination from drugs that are given during labor and delivery. So if they're given any drugs for labor pains, we might be able to see them in the meconium. It just kind of depends on how long the birth was. There's a lot of various factors in that, and whether or not there's any contamination. Umbilical cord. This is the one that we particularly like here at USDTL. It forms during weeks 4 to 8. It does have a nonlinear growth during term. So what that means is that not every umbilical cord is a different length. They're not all going to be exactly the same length because it's just not a linear growth pattern. But it is homogeneous, and so throughout the tissue itself, the drugs will deposit, and you see a very homogeneous. So no matter what section you take, you're seeing the same amounts of drugs found in the tissue. And so that provides us a really nice opportunity for testing. It's also universally available at birth. Every baby has one, so you don't have to worry about loss like you do with meconium, or the challenges of urine collection, or the fact that babies don't necessarily have hair. It is a reservoir specimen, so it does collect those drugs over time. And the neonate is the owner of the tissue. So that's an important piece of this information, is that the umbilical cord belongs to the newborn, not to the mother and not to the parents. So you now have a new baby and a new patient, and you're testing that new patient. And so doing that testing typically allows you to avoid some of the complications and challenges that are faced when you're testing the mom. Drug presence indicates in utero exposure again from the third trimester, and again there might be some crossover in some of the papers that have been seeing. There might be some second trimester exposure, but it'll be near the end. Same problem as we would see with meconium. The mother will metabolize drugs, the placenta will metabolize drugs, the fetus might metabolize drugs. So there's all the different opportunities for drugs to be metabolized. There is homogeneous distribution along the cord, and it rarely includes drugs from labor and delivery. And again, we say rarely, but there is always that a chance that it might, but it's rare. At this point, you can also go to our website. We have a wonderful YouTube video available on umbilical cord and meconium drug testing that's available for everybody to watch. I do highly recommend it. So as I mentioned earlier about the meconium with certain drugs has really high amounts in it. And so some people will say that meconium is in fact the way to test. And some people will say, no, umbilical cord is the way to test. The answer is it's what's best for the newborn and really what's best for your processes. While we prefer umbilical cord, some states require meconium. So knowing what is required by your state is more important than anything else. There was a few papers that talked about concordant results between a meconium and umbilical cord. So there are concordant results or results that agree with each other in 3 different papers, one by Montgomery, one by Marin, and one by Palmer. And you can see that they tested different amounts of samples, 118, 37, and over 2,000. Now, the first 2 were paired. So you had a paired meconium and a paired umbilical cord from the same newborn. That third study with the 2,000, they were not paired. So they were looking at overall drug positivity. And when you do that, you have to make sure that you have the right cutoff. So they did found a greater than 79% agreement. And it was a retroactive study at an academic medical center. So it's not perfect. It has challenges to its study design, but it does show quite a good number of agreements in there. Now, there are 2 studies that were done by the same researcher, Colby, and what was found in those 2 studies was that in these different parents, there were some discordance between the testing. As I mentioned earlier, one of the challenges is that there are different levels of drug in the different matrices or the meconium and the umbilical cord. So having the exact same cutoff for both of those doesn't make sense. You're going to want different cutoffs. The Colby paper primarily used the meconium cutoffs, and I've tried to apply those to umbilical cord. And so that didn't work really well, in our opinion, but it was still reported out in the literature. So I don't want to pretend like there is nothing wrong with it, but it's always important that we read these articles with a critical eye and try to understand what the challenges is, what isn't being said, what the testing is. And so she found that meconium was better for opioids, even though her first paper did kind of agree that for most drug classes, umbilical cord was equal to meconium. So, but she thought it was better for opioids. And she's not wrong because there is that higher concentration in meconium, so it's easier to detect for opioids. But if you have appropriate cutoffs, you'll be able to find in the umbilical cord, and so that's what we find. So the last thing I want to leave you with is what sample is best. Is it umbilical cord, is it meconium, and is it urine? Again, it's going to kind of depend on what you want to look for. If you want what has easiest collection, it's going to be umbilical cord. Windows of detection, again, third trimester, and then urine has days of detection window. Specimen availability, urine and umbilical cord are universal. Every baby will have those, just harder to collect the urine. And again, for meconium, there's up to 20% of the time where it's passed during the delivery process, and so you can't collect that. Specimen size, umbilical cord, it's available at birth, and we typically ask for the 6 inches closest to the newborn. And so every baby has that. Meconium is going to be variable. There's going to be grams of it. It has a delayed collection, and you need to make sure that you send enough of it in order for us to, especially if you're doing a forensic test, in order to do the screen and then do the follow-up confirmation that's necessary. The same with urine. It's going to be a small amount, so collection ease varies. but also having to have enough so that you can do that initial test and the confirmation test. Stability, umbilical cord is typically more stable. Meconium does have some challenges due to its actual sample type and its pH. And urine is also has more stable. And then composition, umbilical cord and urine are homogeneous versus meconium, which is the heterogeneous. So like that chocolate chip cookie that I mentioned. So we wanted to present to you today evidence-based newborn toxicology with resources and sites that you can look at. We know that evidence-based practice is a important role for everybody now, and we wanted to be acknowledge that and be aware that we need to present in such a way that helps you make those decisions based on the fact that there's evidence in literature that shows the best way to do newborn toxicology. With that, I would be happy to take any questions. Thank you.
Subscribe to our channel to see more videos like this.